we have these numbers. What do we do from here? What do we do with this data?
Right. Are we able to actually do something about that?
Who are we actually going to provide this vaping education to?
Welcome back to Everyday Epidemics, Partners in Prevention. Today we are building a logic model. This is part 5 of our 7-ish part series, and today we're doing something really exciting. I'm Mitchell Kilkenny. I'm a tobacco prevention expert here working in Douglas County Public Health.
And I'm Sidnee Hedrick, and I work for Adapt Integrated Healthcare as our prevention program manager.
On our previous episodes, we've explored the strategic prevention framework, starting from the beginning and now going through the actual steps in the nitty-gritty of what it takes to implement and plan and assess a prevention program.
Yeah, so far we've really taken a deep dive into step 1 assessment. We've talked about capacity building in our previous episode, and today we're going to go into step 3, which is planning, where we're going to bring together that data that we collected during assessment, the resources and readiness that we learned about during capacity, and apply it to planning phase where we're going to build a logic model. And this logic model is really going to be our roadmap to figuring out what programs are going to be effective to implement based on the priority problem in our community.
And today we are in the DCSmokeFree studio, and we're going to have some great shots for you. So if you're listening out there and you have time to actually view this, that would be great, because we're going to have some great graphics for you as well to build out your logic model and become better prevention experts.
Yeah, we got the iPad here. We're actually going to walk through an example that we have actually done in our work here in the community. So it's going to be great. It's going to be real life. This is what we're doing to address some problems in Douglas County. So hopefully this is some kind of like hands-on learning that we can take away from this episode.
Yeah, so let's jump into it.
So we're going to talk about the components of a logic model, and there's really 5 core components. And we start on the left side with our priority problem, and it goes through our logic model all the way to our desired long-term outcomes. In the middle here, we have risk and protective factors that are linked to our priority problem, our chosen prevention programs and practices that we're going to hopefully implement in our community, our desired short-term outcomes that would come from those practices, and then that further links to then our desired long-term outcomes. And so, as Mitchell mentioned, we're going to go through kind of how we apply this logic model to the priority problems in our community. One thing I want to note is that you can see I've got some arrows linking priority problem to long-term outcomes, and then also risk and protective factors to short-term outcomes. And that's going to be really important as we build this logic model to make the connection between the problem and the long-term outcome. And we'll get into a little bit more of what that looks like when we get into our examples.
Yeah, so that's the basic rundown. And now I think we'll just kind of dive into the first piece of this, which is developing our priority problems. What are they? Do we have some data to support this? How do we figure this out?
Yeah, perfect. So this kind of takes us back to our original step 1 assessment, right? How do we know what problems are in our community, and how do we prioritize them to know where our prevention efforts are going to be most effective? So we can take it back again to our student health survey data that we talked about in the assessment episode. Do you want to walk through some of this data?
Yeah, let me just read this out here. So this is our priority problems. This is data that we've collected from the 2024 Student Health Survey from 11th graders. So when we looked through this data, we found that 7.5% reported past 30-day use of alcohol. So that was actually down from 18.9% reported back in 2020. We also saw 9.7% reported past 30-day use of marijuana. Again, a little bit down from 11% in 2020. When we look at vaping products, we saw 15.8% reported past 30-day use. Again, down from 2020 of 21.2%. When we looked at past 30-day use of illicit substances like fentanyl, we saw a 0.1% reported use, while in 2020, we saw a 0.0% use. And finally, we looked at problem gambling, and we saw a 22.6% reported recent gambling, which is up from 11.8% in 2020.
Yeah, that's great. So we can see from our assessment data There are several problems, especially we focus a lot on our youth, right? Because we know that if we can delay or prevent that first use of substances, they're less likely to develop some sort of substance use disorder later in life. And so, the survey data is really helpful in helping us identify priority problems. But it's like, okay, we have these numbers. What do we do from here? What do we do with this data?
Right.
And we actually have some factors that we can look at to identify which problem might make most sense to address.
Yeah, so we have a lot of these problems, and we need to pick one or two that we can actually work on. And so how do we do that? We have to identify it. So we go through these 4 steps here, right?
Yeah, so there's 4 factors. Magnitude, which talks about how many people really is this problem impacting. There's severity, which is really about what's the impact, what's the true harm that's coming from that use of the substance or that behavior. The trend, which is talking about, is it getting worse or better in the community? And then changeability. Do we have what it takes to actually change that problem? And this is going to go back to our capacity step, knowing what our resources and readiness are in our community.
Yeah. So let's walk through a couple of these priority problems, and let's address the magnitude, the severity, the trend, and the changeability. Do you have one you want to start with?
Well, let's think about magnitude. So looking back at our data, we saw that the highest percent of problem use among the youth was, first of all, gambling. That was the highest, right? I think 22.6 maybe.
Right.
Let's put problem gambling under magnitude as a priority problem. There we go. We got it. And then the second highest priority problem was vaping, if you remember. So maybe we'll put both of those under magnitude. They were impacting the most number of students. So there, we got problem gambling and vaping under magnitude.
Right. So these 2 problems are affecting the greatest number of students as reported on this 2024 Student Health Survey.
Yes. Okay, great. So let's move to the second factor, severity. Which one has most harms?
Yeah, and this is kind of a tough one to answer, right?
Yeah, I would say. Because you can consider immediate harm, and you can also consider long-term harm.
Long-term impacts, yeah. Well, I can speak to vaping, where we do know there are long-term health complications and health harms in the long term, but they take 30, 40 years to occur. We do see some short-term effects, shortness of breath, higher rates of asthma. We've also had anecdotal reports of students trying to run upstairs and do things, and they're having a harder time achieving or working on those activities.
Yeah, and I think mental health also is a big
higher rates
problem.
of depression, anxiety.
Yeah. Okay, so let's put vaping as a higher severity problem.
Okay.
We can also think about severity as what's going to cause the most harm with like one use. And so when we think about that type of behavior, a lot of times we're thinking about illicit substance use,
like
especially
fentanyl.
Fentanyl, huge, right? Because fentanyl poisoning is happening a lot.
Right. Takes just a very small amount to have a fatal overdose.
Yeah, exactly. So I'm going to put illicit substances up here as one of our problems that we could consider a severe one.
Very severe, right?
Okay.
But does it affect very many? What's the magnitude of illicit substances?
Right. If we go back to magnitude, this one's very low. Okay, so let's look at trend now. Which ones, if we were looking at the data, were really getting worse over time?
Well, I think when we looked at all of the data, a lot of them were actually decreasing, right?
Yeah, which is a really good sign.
Yeah.
There was actually one, though, that was getting worse, and that one was gambling. So I'm going to copy and duplicate gambling and bring it over to a negative trend. I don't know if we necessarily need to put any others there as far as negative trends.
Well, so one thing we could just briefly kind of look at is there is some local data. So sometimes we have the great data from the state. Sometimes we do our own local surveys, and we'll see what do the trends look like back in 2023 for when we look back grade level for vaping.
Yeah, and this is tobacco use in general, but this is good to note because when Mitchell did a local survey, the 2022 to 2023 or 2020, excuse me, to 2023 data actually showed an increase.
Yeah.
So that's different than what the state survey showed. Again, highlighting the importance of multiple data points. But so Mitchell's right. We could take this and say, well, depending on the source of data you use,
Right.
vaping is actually also trending in the negative direction, meaning more students are vaping. Yeah. So we can go ahead and put that, I would say, also in our trending category.
Worse, yeah.
It is getting worse.
So one more thing I want to point out here real quick is because I just want to show that because it's so impactful, I think. Yeah, when we look at just sixth grade use from 2019 to 2023, we see a very strong rate of increase from 2019, 0% reported to up to 7.3%. So not only are we seeing an increase in students using tobacco products, but younger and younger students are. This adds to the level of trends and maybe a little bit of the severity of the problem. Like, yes, the health complications aren't, wild. We don't have immediate health complications, but we're having younger and younger folks use tobacco and nicotine substances.
Yeah. And we know that the younger they use, the more likely that addiction can occur. Mm-hmm. And this also is a good point because it's going to matter when we decide what is our focus age group when it comes to implementation of a program. You're going to see later on that one of our practices that we chose is education. And we have to choose who's going to receive that education.
Right.
And when it comes to prevention, we're really trying to reach more students before they've started using. And so this data is going to be really important when we get to the implementation phase on who are we actually going to provide this vaping education to.
Okay, so we've addressed the magnitude. We've looked at the severity for some of these problems. We've identified some trends.
Yep.
We realized problem gambling is at the top, but vaping, depending on what data sources you look at, is pretty close behind.
Yep.
And then we have this changeability. What is this changeability?
So can we influence change through prevention efforts? And again, a lot of this is going to be, is our community ready to address these risk and protective factors? Is our community ready to address these priority problems? So for example, I will say from my experience as a manager within ADAPT's prevention program, we know that problem gambling is trending. We also know that the prevalence is pretty high, the magnitude is high. However, knowledge of this problem and awareness of the harmful effects is pretty low. And you have to have increased knowledge and increased awareness in order for you to have community buy-in. We talked about this in capacity step. So when we're considering changeability of problem gambling among youth, I would not consider it to be very high at this moment. And that's a really important factor when you consider which priority problem you're going to choose. Because if your community isn't ready to address the problem, you're going to be spinning your wheels for a long time with no forward progress.
So it sounds like a lot of what you're saying is that problem gambling is one of those problems that has a high magnitude of students, has a high severity, and is trending upward. But are we able to actually do something about that? And you're like, well, we could implement some things potentially, but our community is not super ready for those types of changes at this point. And you were mentioning the information about it, the overall education about this issue.
Yeah, absolutely. So when we consider changeability, it's really like, well, what is our community not ready for? We have identified problem gambling as one. I also think maybe we're not quite ready at the school level. This is, again, talking about youth and in this data. Maybe they're not quite ready for illicit substances conversation. Some of them are, but some of them are like, well, it's not really impacted me. And that's kind of true, right? The magnitude, as we spoke to, is very low. So then we're down to really vaping when we're considering the other categories and other factors of magnitude, severity, and trend, because our top three from those were problem gambling, vaping, and illicit substances. So based on those, the highest changeability seems to be vaping among youth.
Yeah, absolutely. There's many ways that we could work with the community to make real change with our problem priority of vaping.
Yeah. Lots of conversations been had, and the community seems ready.
Mm-hmm.
So After going through our factors, we're going to go to build actually our logic model. So here is kind of a template one could use that breaks down priority problems you could list, risk and protective factors, your programs and practices, and again, short and long-term outcomes. So we're going to go ahead and say, you know what? We've identified our priority problem. That's going to be vaping. I'm going to go ahead and write in youth vaping under our priority problem as we build our logic model. Because we talked about priority problems being linked to long-term outcomes, I'm also going to go ahead and insert our long-term outcome, which would be
to decrease youth vaping. That's our overarching goal here.
Exactly. We want to decrease youth vaping. When it is broken down like this, it makes sense, right? It's very simple. Our goal is, or our problem is vaping, and we want to decrease it.
Yeah.
That's our long-term outcome. When you really get into the nitty-gritty of this work, you're going to have to make this more into a SMART goal, right? The specific, measurable, attainable, realistic, time-bound, all of our factors. So it might look something more like, we want to decrease youth vaping among 6th grade students in Douglas County by 10% in 3 years, right? There's a lot more pieces to this goal, but when we're building and starting with our simple logic model, we can just say, we want to decrease youth vaping.
Yeah, absolutely. And we talked about earlier, but a lot of these things will affect, there's different, you might change your specific long-term outcomes by things like funding. Maybe you only have funding for 6 months, maybe you only have it for a year. And so you might change that based on the capacity that you have, the constraints. So there's a lot that might affect your particular long-term outcome.
And because of that, that might also directly influence which priority problem you're going to choose. If you can't influence a priority problem within the next year, and that's when your funding is going to run out, you probably shouldn't address that problem.
Yep.
Okay, great. So now that we have identified a priority problem that we want to address, we can't necessarily directly attack that problem. We have to think about the factors that are influencing that problem. And so these are our risk and protective factors that we've talked about in previous episodes. The risk factors are those that are going to lead someone or increase their likelihood to use a substance, or in this case, increase their likelihood to vape. Protective factors are those that are going to buffer that, decrease their likelihood to vape. And so if we can identify some of those risk and protective factors, that's what our programs are actually going to address. So again, to identify those, we need to go back to our data. What is our community telling us that's contributing to this youth vaping problem?
Right. So we can look back at our data, at the 2024 Student Health Survey data, 11th graders, and we see some interesting facts. We see only 65% of students believe that there is moderate to great risk in harming themselves from vaping. 30% of students were moderate, while 35% said great in risk in harming themselves from vaping.
Yeah, so that tells us that there's a fairly low perception of harm when it comes to vape use.
Exactly. While 81% of students use flavored vape products.
Yeah, of those that are vaping, 81% are using vape or flavored vape products, which there's been a lot of talk about, how the flavors are enticing to youth, and that's been a marketing strategy by Big Tobacco, and there's something to be said for that. So we just want to keep that in mind, but maybe that's a factor that's contributing in our community.
Yeah. Some of the other things that we saw was that 26.5% access their vape products from friends or family and members who are 21 and older, while 20.6% access from friends or family who are under 21. So we perceive that to be peers. We also saw that there was some access from retailers. So 17.6% of students reported getting their tobacco products from stores, local retailers.
Which is quite significant if you think about it, almost 1 in 5.
Almost 1 in 5. That is, it's quite a few students.
Yeah.
We also saw 62.8% of students reported seeing tobacco and vaping advertising in the past month. So students are exposed to these products and see them on a regular basis, which may influence their decision to utilize or use these products.
Yeah, there's actually some research that's been done that shows that the more students are exposed to vaping and tobacco products, the more likely they are to use them in the future. So this is really important, actually, knowing that we have quite a few of our students, majority, that are actually exposed to this type of advertising.
Yeah, and this helps us because we've identified not all of the risk and protective factors, but several of them. They're evidence-based, which is important to us. And these are the things that we can actually focus on, right?
Yep.
We can focus on these things and we can try to make change in these areas, but we need to identify which risk and protective factors match with our priority problem.
Yeah, and it's important to note, too, that some risk and protective factors are going to be easier to identify than others. We have some here that we just went through that are in the student health survey, so that's really helps with like quantitative measuring if we were going to then measure this as a short-term outcome. But we also know we can collect that qualitative data, those anecdotal reports. And what we see and what we're hearing from students is that they're saying everyone at school is doing it. So they have this perception that most peers their age are vaping, which then increases the likelihood that they're going to vape. They have this social norm that that's what's happening, when in reality, it's really not. It's just a misperception.
Yeah, our data says that it's not the majority of youth, even though it feels like it at schools, because you see so many people doing it. It is a large number of kids, but it's not everyone.
Right. We also hear from school administrators, they're concerned about the youth vaping in schools and school bathrooms. They've actually implemented some vape detectors in some of our school districts. They've shared some of those reports with us, showing that they're getting a lot of alerts in those vape detectors. So that's some more information that helps us know what's contributing to some of this problem.
And also, in some ways, this data can help us determine the changeability, right? If this is now affecting student and administration, they're more likely to take a stand and say, hey, maybe I will help you address some of these problems.
Yeah, exactly. If schools are recognizing, right, the problem, it kind of goes back to knowledge and awareness, and now they're seeing it. They're seeing how it's impacting their students and the student success, and they're saying, hey, how can we address this? And that's when we know that they're ready to implement a program.
Yeah.
So there really are two factors when it comes to identifying risk and protective factors that we want to focus on. And those are going to be, we've kind of mentioned it a little bit. It's going to be our importance scale and our changeability scale. So importance meaning how much is that factor contributing to the problem?
Right.
And changeability, again, meaning
how likely are we to actually make a difference in that?
Yeah.
And so, like, one example of that might be what's something with a very low changeability, but a very high importance level. And that could be something like policy. So we could imagine a complete ban on tobacco products. If students weren't able to buy this or anybody able to get these products at all, would that increase importance? For sure, we'd be way up high on the importance level.
Yep.
But is that actually practical? Is it possible? Can we make that change? Probably not, right?
And like within a reasonable time frame, right,
Yeah.
too? So some factors to consider. That doesn't mean that policy work is not important, because for sure we know policy has great impact when it comes to substance use and other harmful behaviors. And there are actually lots of people working on legislation and trying to make impact there.
Yeah.
But sometimes when you consider the local level, that changeability piece is just too low.
Yeah. So
But
generally-
again, it doesn't mean we don't try sometimes.
Absolutely. When we think about policy in general, this is, again, generality, not a blanket statement, we tend to see areas right up in here where we have a lower changeability. It's much harder to pass policies, and that's a good thing, right? We don't want to pass bad policies. But policies tend to have the highest impact, the highest amount of importance. And so generally, we see stuff here.
Yep. So if we go back to our list of risk and protective factors, we see that access from retailers is actually like the third place that most students get. Even though we mentioned 17.6 is still like a significant amount.
Number, but it's not the highest on the list.
Exactly. But if we're to choose, of these three access points, influencing friends and family not to give is going to be difficult to change. Influencing peers not to share their vaping products also going to be difficult to change. But can we do something about retailer access? Yes, we can. We actually have programs in place for that.
Yeah, absolutely. So we have something called the TRL program, which is short for the Tobacco Retail License. And so retailers have to apply to sell tobacco products. And through that licensure, that gives public health authorities in the state of Oregon ways in order to enforce that they're not selling to minors, because that's against the law.
Yeah.
And if they do violate the law, we can issue penalties and fines. And so that's one way where there's a high changeability. We can crack down on the number of retailers who are selling to kids.
Yeah. So others that we could address that also have high changeability, I would say, are, this belief that it's not harmful. We can address that through education.
Right.
Kind of the social norms aspect, where believing that most of their peers are using. We can also address that through education. So let's go ahead and go back to our logic model and start filling in some of these risk and protective factors that we think are going to be most important to address that will then impact our priority problem.
Okay.
Now that we've identified our risk and protective factors that we want to address, we can go to our short-term outcome column and actually fill it in, because as I said,
they're linked, right?
Yeah, these should directly reflect our priority factors. So if low perception of harm is one of our factors that we want to address, the short-term outcome that links to that would be
increase our perception of harm.
Exactly. When it comes to retail access,
we want to decrease retail access, right?
Yep.
So students aren't able to just go into any convenience store and buy their favorite vape product.
Exactly. What was our next one? Belief that everyone is vaping. So increase understanding.
Social norm.
Yeah. And so then for the refusal skills, if that's a protective factor, we actually want to increase that.
Yeah.
So increasing refusal skills.
So this is a list of our short-term outcomes that we can achieve by addressing those risk and protective factors that we've listed.
Yeah, absolutely. So we're 80% of the
We're
way
almost there
through our logic model already, just by identifying our priority problems, identifying risk and protective factors that are directly influencing that problem, and then connecting our short and long-term outcomes.
So now we're missing that how piece, right?
Yeah, that final middle piece, the glue that links what's the problem to the desired outcome, and that's where selecting appropriate prevention practices comes in.
Mm-hmm.
And so when we think about the types of programs and practices that we want to implement, there's, again, a few factors that we want to consider, and I'll take us to what those are. So the three factors.
Yeah.
Effectiveness. Is there evidence that it works?
Mm-hmm.
Has research been done? Has it been done before? Right?
Right.
There are times when we maybe need to do a grassroots effort.
Mm-hmm.
But lots of times there are programs out there that have been done, have been replicated, show rigor and reproducibility, these science terms, right? This, again, is the science of prevention.
And there's different organizations who do this. This is something that I want to point out, too. Like, we use a lot of counter tool stuff. Counter tools, shout out to them. They're great. But also there's universities, Stanford, there's other places out there who do the research into deciding which program works best, even tobacco cessation programs like Colorado School of Medicine. So there's a lot of different places who specialize in just doing the research on how to implement these programs and what are some of those best practices. Yeah,
and when we can, we want to choose those that have shown proven to work, right?
And you started saying that some of them aren't necessarily there yet, right? Sometimes they're emerging.
Absolutely, yeah. So we can actually, there's this whole kind of level of effectiveness that we can look at when it comes to evidence-based or even non-evidence-based programs, right?
Yeah. So on the left-hand column, we have this strength of evidence, and it goes from weak to strong. And what we can see is that the strongest evidence with the strength of evidence plus the strongest program or practice effectiveness is going to be something that's well supported, that's a standard model, or that's exemplary in its program.
And how does it get that title?
How does it get? Well, by lots of research, by data, by studying what works, and time is a big one too.
Yeah.
do they have all this research, the time? Then people start implementing it and practicing it, and we can replicate those results. Is there fidelity
Yep.
in the results? I think all of that is important. Can we implement the program with fidelity, I guess is the better way to say that.
Yeah, absolutely.
What is fidelity, by the way?
Fidelity is basically, are you implementing the program as it was designed, as it was intended, as it was written, so that you can say our results, yes or no, match what they did because we're matching the program exactly as they ran it. So ideally, we would be choosing, far on the left side, well-supported models.
Right. But you don't always have that. That's important to know. It's not every program. These things are new and emerging. If we think about new tobacco products, things like nicotine pouches, commonly known as ZYNs, we don't have well-supported evidence for tobacco cessation for those things, but there might be a promising or supported program from which we can choose from.
Yeah, exactly. So the better programs are over here, well-supported, still great. Promising and emerging can be great too. We want to kind of avoid those that are inconclusive or just didn't determine a result, and that could just be based on how they did their methods. Maybe the actual evaluation process was inconclusive, and so those aren't really programs we want to follow. It's also important to note that there can be programs that have been out there for a long time and have been researched and in the beginning thought were going to be, emerging and promising. Yeah. And they actually ended up being ineffective.
Right.
And some actually harmful.
Yeah. And so we really want to avoid any programs that could provide harm or just are going to be ineffective, because then we're just wasting our time and our dollars, which are always limited.
Exactly. And it's also going to be important to remember this if we ever do use an emerging or promising practice, to make sure we're doing our own evaluations to make sure that what we're doing is not causing harm versus helping. So
this is the reproducibility of this. Is when we implement the program, we ensure fidelity.
Yep.
Is this reproducible? That is to say, are we getting the same results that happened in the study? And if we're not, we should be aware of that.
Yeah, absolutely. And if we are, we want to let the developers know, because that can contribute to them going up this scale from promising to supported to well-supported. Mm-hmm. So we actually can contribute to programs becoming evidence-based. So that's, again, one factor to consider when we identify a program or practice,
right?
Is the effectiveness. Another one...
There's two other pieces to this, right? Which is the conceptual fit and the practical fit.
Yep. And these are probably even more important than effectiveness, even though effectiveness is a key part. If we don't have these other pieces, it's not going to work.
Yeah.
So the conceptual fit is asking the question, does this intervention or program directly address the priority, risk, or protective factors that we've identified that we want to address?
Right.
If it doesn't, how are we expecting that outcome to change?
Right. We're implementing this program for a reason, because we want to address our risk and protective factors to hopefully get our short and long-term outcomes. But if it doesn't have good conceptual fit, then we're not changing the things that we're trying to change. It doesn't make sense.
Yeah. And so like an example of that could be, well, we identified a risk factor that most of our youth are accessing, or the majority are accessing through friends and family 21 and older. Mm-hmm. Let's do a TRL program.
Right. Yeah.
Well, okay, in practice, the TRL program might be doing good, but you're not going to be directly impacting that risk factor that you chose.
Yeah, we're not impacting our risk factor, and maybe we're achieving some of the same long-term outcomes, but not our short intended outcomes.
Yeah. And long-term outcomes, again, are harder to measure. So that's why we want those short-term outcomes. If we know we're impacting short-term outcomes that ultimately contribute to longer-term outcomes, we have quicker results to go off of if we need to, change what we're doing, versus learning 5 years later that program was not good. More people are vaping. That's why it's really important to track those short-term outcomes.
Absolutely. And then we have something called a practical fit. And that's, do we have the capacity to implement the intervention or the program?
Seems like we always come back to capacity, right?
Yeah.
It's so important, because if your community is not ready, they're not going to have the buy-in, and therefore the program just won't implement as intended. It just won't work.
So maybe an example of a bad practical fit might be a strategy or risk factor to decrease problem gambling. And we come up with this really great evidence-backed course that's going to address problem gambling. And we go to schools and say, we want to implement this. And they say, No.
Yeah, this goes back to why we didn't choose problem gambling maybe as our priority problem, because we, forward thinking, knew that this capacity piece was going to play a role. And so, yeah, we decided that's not a good practical fit. The community's not ready. But when we look at some of our other options for like addressing vaping, we want to keep this in mind. Is our community going to be able to actually address that?
Yeah. And then again, we look at that data before and we go, oh, yeah, students, teachers, administrators are all having issues with that. And so we're trying to find the intersection between what's effective, what has good practical fit, and what has good conceptual fit.
Exactly. So when we look at our identified risk and protective factors, we said low perception of harm we want to address, easy access from retailers, belief that everyone is vaping, and then some refusal skills as a protective factor. There's kind of a few different areas of programs or practices that we can consider. So one of them is education. Another one is policy. We've talked about that. And then there's also just kind of like community efforts, community norms that we can look at.
Yeah.
And so we've actually put down a few examples. This is not a complete list. These are just some things as examples in each of those categories that we can consider when trying to identify the best practice to address these risk and protective factors.
And when looking at education, Sidney, you actually put together you've done this whole piece, right? You've put this together and made this whole thing happen.
Yeah, and really I want to highlight again Jess Hand's work, because a lot of this was done with Thrive Umpqua's partnership. And what we, again, were trying to look at is what is a good education program that we can use to address low perception of harm, to address peer refusal skills, to address the belief that everyone is vaping. All of my friends are vaping. So what do? We go online, we do our research. This is where research, again, comes into play. We have to figure out what has already available, hopefully an evidence-based program that we can implement in our community. And so I've listed a few here that we looked into. The Truth Initiative's Vaping, Know the Truth, the Catch My Breath program, and then Stanford Reach Labs, You and Me Together Vape Free. I will say that pretty much all three of these programs were addressing our risk and protective factors.
Okay.
The fact that they're going to increase knowledge of our harms, they're going to practice some refusal skill building, and they're going to talk about the norms around peer use. So, what is the reality of peer use versus what you're perceiving?
So they're all, it seems like the effective piece, they're all going to be effective for the things that we want to do.
They're all going to be effective, and they all had that conceptual fit that they're targeting our chosen risk and protective factors. So for us, it really came down to practical fit and what made most sense for our communities. And when we looked at the Truth Initiative's vaping program, it turned out it was an online program, which for some situations that might be better. It might be easier to get an online program in. If there wasn't a lot of buy-in from the school, they didn't want to give you a lot of time, an online program might be your only way.
Right.
But because we had some buy-in from the school, and because we know that there's more benefit and more learning that comes in an in-person setting, we really wanted to choose an in-person program.
Yeah.
So that left us between Catch My Breath and Stanford's program. And the difference here was one was 4 and one was 5 lessons.
Yeah.
And again, they gave us their time, but they're also short on time to give us.
Yeah.
So if we can get the information in 4 lessons rather than 5, it still show effectiveness. It made a little bit more sense for us to go that route. So we actually chose Catch My Breath as a program to implement within Douglas County Schools. And so I'm going to pop back up to our logic model and write that in as one of our programs and practices.
Yeah. And even thinking about 4 lessons versus 5 lessons, 1 lesson per week, and there's only 9 months of the school, that's 1/9 of the school. I mean, that's roughly, one day per week, but a lot of the school's time. So just adding 1 more lesson in there does take quite a bit of a student's time, a school's time, administrators, teachers, all of that.
Absolutely. Okay, so let's go back to our different strategies, because we know that we need to address these risk and protective factors not just one way. Multi-pronged approach is going to reach and have a greater impact.
Right.
So we've chosen an education program, but let's look at some other practices that we could put in place that might address these factors.
Yeah. So we can look at policies, which could help us address our risk and protective factors. And when we look at flavor bans, increased taxes on vaping products, advertisement restrictions, and tobacco retail license enforcement, all of these have really good effectiveness. We all know that there's evidence that's going to help decrease our overall goal, which is youth vaping.
Yep.
And then also when we look at, I always forget the name of it. What is it called? The
When
conceptual
we look at
fit.
conceptual fit, right? Which one makes most sense?
Right. So at conceptual fit, they all kind of make sense. They all have a good space for us, except some of these policies are tougher in our communities, which is more of that practical fit.
Well, I will say, so the conceptual fit, I think they all make sense in a way. But if we're looking specifically at the risk factor that we chose, which is easy access from retailers, it makes it a little bit more obvious which one is more of a conceptual fit, right? Which would be the TRL.
Absolutely, because flavor bans aren't going to, address any of the tobacco sales. Well, it could address a little bit of tobacco sales of retailers, but increased taxes.
It's not going to impact access.
Right, exactly. And so to address those risk factors, we need to look at the TRL program as well. And so does it have conceptual fit? Yes. Does it have practical fit? Absolutely, because we already manage that retail license through our local government.
Yeah, so that's one we just kind of continue to implement to make sure that our access doesn't get worse and hopefully improves over time.
Yeah,
so I'm going to go ahead and also add that to a strategy that we have in place to address our retail access. So TRL program. Okay.
And then our other risk factors that we're looking at are belief that everyone is vaping and also some peer refusal skills.
Yeah. And so we are addressing those through the Catch My Breath program, but is there another way to address it, right? So we're addressing it at the education school level. But when you look at possible strategies, the community level is really important too. We think about prevention at the individual level, the relationship level, the community level, and the societal level.
Right.
So if we can have a touch point in all of those or more than one, the greater impact we're going to have.
Yeah.
So we have individual level through education. Can we do something through community level?
Sure, and there's lots of examples that we've included a couple here just for reference, but mentoring programs, or what about counter marketing and social media campaigns?
Yeah, what about it?
What about
Mitchell,
it?
you know about it.
Well, exactly right. So one of the things that we have looked into and actually actively do is our DCSmokeFree campaign. So can we provide community level education, not just to youth, but to parents, to all levels of our community, to increase our education about the social norms of vaping, tobacco use, and nicotine products.
Absolutely. So let's add that as a third practice.
And you also have a media campaign too, don't you?
We do. We have a media campaign. It's called Free to Be. It doesn't necessarily address these risk and protective factors particularly, but it's all about encouraging drug-free living by youth showing what they can do and what they can be when they live drug-free lives.
Okay. It seems like there's a little bit of overlap in all of that. Sometimes that could bleed into refusal skills.
Yeah,
or other
absolutely. Maybe even the belief that everyone's doing it. If there are more peers that are participating in our campaign showing that, no, we're not doing it. These are the things that we're doing because we aren't, and what we can do, then yeah, I do believe that some of these could bleed into each other.
Mm-hmm.
Awesome. So, wow, look at that.
We've filled out a logic model. Incredible. That's
amazing. Okay, I'm actually going to go to our little cleaner version over here.
Yeah.
Where it's not just my scribbles.
So let's kind of recap where we're at. So we started with this logic model. We had priority problems. We looked at our risk and protective factors. We haven't implemented yet, but we've looked at what programs might help improve or reduce our risk or protective factors. We wrote out our desired short-term and long-term goals.
Yeah, and look how this all connects, right? So low perception of harm is being addressed by the vaping program. It's also probably being addressed by the campaign. Belief that most peers vape is being addressed by the education program. It's being addressed by the media campaign. Retail access is being addressed by the TRL program. Refusal skills are being addressed by the vaping program and the media campaign. So it's really great when you break it down like this, you're seeing the impact of your programs and that they can impact multiple factors.
Yeah.
And that you can have multiple programs impact the same factor. And the more overlap you have, the better, because you're going to have more effectiveness in reducing or impacting those risk and protective factors.
Yeah.
And then we can, at the same time, link this on the other side. So the links here should match here, right? Do we have increased perception of harm from our program? Are we increasing knowledge about the number of students that vape? Are we increasing refusal skills? Those should all be components of that program, which it is.
Yep.
The TRL program, again.
Are we decreasing retail access?
Is it decreasing retail access?
And again, the media campaign, are we addressing a multitude of desired short-term outcomes?
All of the things.
Yeah.
And when we get to evaluation, it'll be really important to know how we're measuring these short and long-term outcomes.
Yeah.
And that lots of times our programs that we choose need to have some sort of evaluation built in so that we can measure these.
Absolutely. Okay, so we've built out our logic model. We've gone through the steps. It took some time, right? It's not easy.
Yeah.
And I think, we did kind of the condensed, shortened version, but if you're doing this at home or at work, working on your prevention campaign, take some time to do this, right? It could take a couple days, several work days.
Yeah.
There's a lot of research involved to figure out what's going to work for you, what's going to have that conceptual fit, what's going to have that practical fit. There's a lot of variables here that we've kind of quickly walked you through.
And again, a lot of it comes back to our partnerships.
Yeah.
As you noticed, when we went through every step, capacity was a huge factor in whether we can address a problem, we can address a factor, and we can implement a program. And so if you're feeling stuck and you don't know where to go, find someone to talk to about it.
Yeah.
See if your goals in your program align, and see if you can come together to maybe work on some of these issues, because that's been very important in all prevention work, and we've seen that here at the local level.
Yeah. So what are some key takeaways that viewers watching this or listening on our podcast should take away from all of this? I think a couple for me that even just during this lessons I've really realized are important are, one, being sure that we're linking our risk and protective factors with our desired short-term outcomes. Because like you explained, it's important that we have, when we get to that evaluation piece, are we achieving the outcomes we hoped?
Yep.
And I think it's easy to skip that step and say, oh, these are the factors, let's do some programs to implement them, and then we never know if we achieve our goals or what those goals are.
Yeah, don't forget, this is step 3 of 5.
Yeah.
Right? So we did a lot of work so far. We've identified the problem through assessment. We figured out who can help us, what resources and readiness do we have. And through planning, we built this logic model and identified what programs we want to implement. But remember, we still have implementation phase and evaluation phase, and we cannot forget about those, because sometimes it can be easy to be like, we've done the work, we've figured out what we want to do, and we're going to do it. But if we aren't careful with implementation, some of these programs can fall apart and we don't get the outcomes we want, and we can blame it on the program.
Right.
But in reality, it might just be the way it was implemented. And then also with our evaluation pieces, we can't determine short and long-term outcomes if we don't have evaluations in place.
Yeah.
And so we're going to be coming back to this logic model as we go through those next 2 steps in future episodes, to make sure that we are, again, trying to implement the program as intended to get these desired outcomes, and then also that we're having evaluations in place to measure the effectiveness of these programs.
Okay, we want to leave you with this. There are 3 big takeaways from this episode that you should know. First one is our priority problems. We just did an example for youth vaping, but in reality, you're likely tackling many priority problems all at once. And you might fill out several different logic models for each problem that you're tackling. Secondly, a lot of these steps are linked. When we look at the risk and protective factors, those are linked to our desired short-term outcomes. And it's important that we evaluate both at once so that we're hitting our intended goals. And later in a few episodes, we'll talk about evaluation, where this becomes extremely important. And what's our third key takeaway?
The third takeaway, I would say, is when we're identifying those prevention programs and practices, that key, the glue that keeps this model together, it links us from our priority problem to our long-term outcome. We want to remember the 3 key factors. First is the effectiveness, and ideally, if there's an evidence-based program, we choose that first. Second is conceptual fit. Is this program or practice going to directly influence our chosen risk or protective factor? And third is the practical fit. Do we have the resources of readiness we need to actually influence that risk or protective factor? If you can get all of those factors in one program, the likelihood that it's going to have the influence you want on this priority problem increases. And that's really what we want when it comes to our logic model.
So that's going to wrap up today's episode on building a logic model. Thank you for sticking through and making it around with us. We do want to give a shout out. We have a survey, because again, we're prevention specialists. What good would we be if we didn't do a good survey? So we ask you to please fill that out. We are offering a gift card, by the way. So we'll do a drawing if we have multiple people, but we are offering some gift cards away if you can fill out the survey in the link below. Let us give us some input, what you liked, what you didn't like, and some more questions on there. So
next episode, we're going to walk through step 4 of the strategic prevention framework, which is all about implementation. So we've done the data, we figured out the problem, we figured out capacity, we built our logic model, we know what program we're going to do. How are we going to do it?
How are we going to do it? And we'll see you on the next episode.
Bye.
Bye for now.